aware to the treatment. Our general objective is to assess the prevalence and factors associated with adherence to treatment among adult patients in care at Jinja Regional Referral Hospital. So our study design, it was a hospital cross-sectional mixed study conducted in Jinja Regional Referral Hospital. Jinja region is, regional referral is located in the eastern region where we have the source of the Nile. Now we have cultural festival called the Nyege Nyege, well known worldwide. It is on now. If you want to come, you can join us. So our study participants, we sampled the 297 participants. So this one for the clearance from IRB, School of Public Health. Then we had clearance from the director, and all the people we interviewed, the patients we interviewed, they had a consent. They consented for participating in the research. Structured questionnaires were administered, and we used the Morisque medication scale. This one is a simple one. You know, patients, when they come, they want to be worked on quickly. So when you are taking a lot of time, asking them a lot of questions, they become tired. So this one is, we use an easy tool which has been tested worldwide to correct the information about their adherence to treatment. Data analysis, we use the prevalence ratios to report the association between the non-adherence and the associated factors. Qualitative data was also used using semantic analysis. In conclusion, diabetes treatment non-adherence was present among the patients receiving care in Jinja Regional Hospital. We found a percentage of 51% among the people we sampled, so which is big. So there is increasing number of medical staff in the health facility who do not only reduce patient overload, and there is a need for increasing the staffing in the hospital, because these patients come and overweight, they become disgusted, and some of them go unattended too. So our recommendations, we have the individual, we have the health system. So we have to identify and address the issue resulting for long waiting time. This one I had mentioned about it. It is because of the patient overload.
Time has finished. Thank you. Now I would like to call the third presenter, Yamdi Kanu. I apologize if I pronounce wrong. Are you going to make in French?
Yes.
Okay, thank you.
1,000 and over 800 deaths occurred. Despite this magnitude, limited information exists on clinical and epidemiological characteristics of road traffic injuries in Sierra Leone. Therefore, our study aimed to describe the clinical, epidemiological characteristics and factors associated with deaths from road traffic injuries at the Connaught Teaching Hospital from 2020 to 2022. We conducted a retrospective study and analyzed data of hospitalized road traffic accident cases at the Connaught Teaching Hospital from 2020 to 2022. Connaught Hospital is the main referral hospital in the country. We extracted data from files of patients and entered that data into Microsoft Excel using a structured checklist. We collected data from February to May 2023. We analyzed key variables, key epidemiological variables such as sex, age, and clinical variables such as type of injury, site of injury, etc. We also computed multiple logistic regression to determine independent predictors of death associated with road traffic injuries. Our findings. A total of 4,839 cases presented at the facility. Of these, 1,539 were hospitalized cases. The median age was 29 among hospitalized cases, ranging from 8 months to 80 years. Males accounted for 78% of those cases. 17% were students. 34% were passengers, and 32% were pedestrians. Most cases, that is 28%, resided in the western part of Freetown. March recorded 13% of all cases in the 3 years. 74% of the cases reported between 800 hours to 1900 hours local time. The most common injuries were lacerations at 44%, fractures at 41%, and bruises at 39%. The most commonly injured sites were head injuries at 54% and lower limb injuries at 38%. Case fatality was at 5.9%, and about 26% of cases discharged against medical advice. Motorbikes with 49% and cars were the most common mobilities involved. For factors associated with death in road traffic injuries, dying from a road traffic injuries had odds of 2.4% more chance to die with people who had head injuries compared to those who did not. Also, dying from a road traffic injury had odds of 0.07 in people who rode tricycles as compared to those who did not. From these findings, we concluded that road traffic accident injuries occurred in all age groups, but mostly among students and pupils. Lacerations and fractures were the most common.
I apologize, I need to interrupt you. We complete the 5 minutes. Sorry. Thank you. A round of applause. Thank you for all presenters. We have now 7 minutes for question and answers.
Thank you very much, presenter. I'm Samuel from Sierra Leone. It's a wonderful presentation from all the presenters. My first question goes to my Liberian brother. The substances abuse. You mentioned a series of drugs like cannabis, sativa, alcohols. Well, which substance mostly abused? I did not see it in your presentation. I want to know. And the more reason I want to ask this question to you is that I did not see one of the key drug that is now widely abused by our youths in the sub-region. Especially we are sharing borders with you in the southern part. What I don't know if you know what normally now is existing within the sub-region we call Kush. How is the status of Kush in Liberia? Because I know Sierra Leone, there is a high misuse of this particular drug, and we are just sharing border with you guys. That's my question for the Liberian guy. The diabetes man from Uganda. Public health actions, which complication of most. You know, diabetes has a lot of complications, as you mentioned rightly in your presentation. You have the diabetic eye, and other complications, diabetic foot. But which one? I did not see. Which complication is mostly found? Commonly. You know, you have a lot of other complications, but I want to really know that. Thank you.
Thank you. Two more questions, very brief.
Merci. Nous remercions.
Thank you very much for to all the presenters. I would like to ask Teresa. I would like to know, in her presentation, she talked about these incidents occurred, but what could explain the occurrence of these accidents? I would like her to shed more light on that.
Yes, thank you. My question goes to the second presenter from Uganda. You presented on the factors associated with non-adherence to treatment of diabetes. We did not see the slide for the results. You only went direct to the recommendation and the conclusion. Kindly comment on that. Thank you.
Last question.
My name is Thomas Ekowell from Liberia. My question goes to the presenter for Sierra Leone, the lady. You said most of the road traffic accidents occur in Western Sierra Leone. Will you mind to tell us the reason why?
Thank you, presenters. You can come and start to answer the questions. Once again, I request to be very direct with the answers.
We'll try. Thank you, my brother, for the wonderful question. You had two questions. One is, if I got it well, which substance is mostly abused in Liberia, and why you didn't hear or see more of Kush that is commonly found in your country, and we are sharing borders. So there was a figure that I presented that showed all of the substances used among the patients at the time. So I mentioned that marijuana accounted for 56.1% of the substances that were commonly used, followed by alcohol and tobacco that were 18% each among the substances that were used. That was indicated. That is the first. And the second question, at the time of this study, 2021, we did not have much. Kush now, if you speak about now, yes. But at the time of this study, we amongst the participants at the time, what we found was alcohol, it was marijuana, and the rest. So even you saw in our literature, we presented that alcohol and marijuana use are on the increase in Liberia. Alcohol and marijuana use are on the increase as at 2021 of this study. So maybe now things have changed. Maybe subsequent studies will outline what you're thinking. Yeah. Thank you very much. Yeah.
Next one.
Thank you very much for your questions. With the first question from my sister, who asked about the case incidents and what would explain occurrence of cases. As indicated in my study, I only looked at the clinical and epidemiological characteristics of road traffic accidents and injuries. Yet, as you mentioned, we know there are several causes or several factors that influence road traffic accidents. However, my study didn't cover that area. But if you like, we can discuss it later. But as I said, limited data exists on road traffic accidents. And that of causes is not excluded in that. For my brother who asked why the western part of Sierra Leone was the highest, it wasn't the western part of Sierra Leone that I mentioned. I mentioned that the western part of Freetown had the highest incidence because the hospital is located in the central part of Freetown, and patients from the west were closer to the hospital compared to other areas that were under the study. I hope I answer your questions. Thank you.
Thank you.
Yes, thank you for the good questions directed to me. The first question was from my friend from Sierra Leone. It was about the commonest complications associated with the non-adherence. These are the neuropathies and the peripheral neuropathies. Those are the most common complications presented with the study group we had. And my sister asked about the results. Okay, the time caught me. But as I told you, 51% of the people we enrolled on the study did not adhere to treatment. Then we found out that men do not adhere. They are non-adherent compared to women. Then also income was also another factor, in a way that those ones who did not find the medicine in the facility, they would go and buy. So those ones who had a better income were more adherent compared to those ones with low income. Then also we talked about the road, the overload of client. People who had the time to talk well with their physicians became more adherent. So that's why we recommended to increase on the staff and to have, you know, we have only one clinic day in a week. So if you miss a clinic day, you will come the other week. So we are saying, let us have those daily clinic days of diabetes patients as other clinics work. Thank you so much.
Thank you. Thank you very much for the four presenters. You can now. Now I would like to call the other four presenters: Isabelle from Rwanda, God Bless from Tanzania, Olubenga from Nigeria.
West Gojam Zone, Ethiopia, from 2018 to 2022. The surveillance definition of hypertension is resting blood pressure of in measurement of 2 occasions which average of 3 readings greater than or equal to 140 per 90 millimeter mercury with age greater than or equal to 18 years. By the end of 2025, 1.56 billion people will have hypertension globally. Over 1.3 billion people living with hypertension globally, and 2/3 of these are from lower and middle income countries. In Africa, 45% of adults whose age is older than 25 years and above are living with hypertension, and its prevalence is raised from 19.7% to 30.8% from 1990 to 2018. In Ethiopia, non-communicable disease accounts for 39% of all causes, from which 16% are accounted for cardiovascular disease. The study aims to fill the information gap by describing the trend of hypertension in terms of time, place, and person over the past 5 years. The study was conducted at Murray Primary Hospital, which is also a surveillance site for hypertension, and it is found in West Gojam Zone, Amhara Regional State in Ethiopia. The study was cross-sectional study design. Data source was secondary data from AHMIS and DHIS2. The outdated AHMIS was used from 2018 up to 2019. Simple app data for resort to solve life is also used for data analysis. The study period was from June 15 to July 10, 2022. The study population was hypertension patients that has get service from the hospital. This is the study area shaded in green. When you come to results, hypertension distribution by age category, as age was advanced, so did the hypertension among both sexes. When you can see here, less than 30 years of age, the hypertension prevalence was 0.2. From 30 to 60 years, 1.2, and greater than or equal to 65 years is 2.4. So as age increases, hypertension prevalence increases. When you come to hypertension cases by sex, females are slightly higher than males. Females account for 59% of cases from 2018 to 2022. When we see hypertension cases by time, when we see absolute numbers, it is already increasing. But since this initiative is new and it has not action or action threshold or any other parameter, it shows only absolute numbers. When you see hypertension morbidity and mortality from 2018 to 2022, it increases. And it accounts to 0.7% of the total OPD cases, but there is no days at all. When you see the hypertension trend by type, essential hypertension or primary hypertension accounts of 64% of all patients. Where when you see hypertension cases by stage, stage 1 hypertension accounts of 74% of cases, and there are 2% of severe hypertension. When we see trends of hypertension screening and enrollment to care in each age category, we see there is increment of hypertension from 5.6 per 100,000 population to 123 per 100,000 population from 2020 to 2022. But out of these patients, only 7.88% are screened. When you see in each category, 13.5.
Sorry, I need to interrupt you. You complete your 5 minutes. Must have all the applause for him. I would like to call the second presenter, Isabelle from Rwanda. Remember, you have 5 minutes.
Present a study called Prevalence and Predictors of Hypertension among Screened Population in Rwanda. It's a cross-sectional study from 2021 to 2022. Hypertension is one of the 5 leading causes of mortality. Globally, 30.8% of adults have hypertension. In Africa, it's resulted nearly to 900,000 deaths in 2016, and it has increased by 82% since 1990. In Rwanda, hypertension affects 15% of the population. These numbers are from the STEP survey that was conducted in 2012. Most people with hypertension are unscreened and do not know their status. The objective of this study was to address the prevalence and the predictors of hypertension in Rwanda. Moving to the methods, it's a cross-sectional study design. The data, these are secondary data that were extracted from the non-communicable disease reporting system. They covered all health facilities countrywide, and also some hotspots where screening were conducted. And the time period was April 2021 to April 2022. All participants that had record were of diastolic and systolic measures were included. The data were extracted, clean, and they were analyzed in Stata version 16. Bivariate and multivariate logistic regression were used to determine the variables that were independently associated with hypertension. Odds ratio, 95 confidence interval, and p-value less than 0.05 were reported. Moving to the result, this is the prevalence. According to this study, the prevalence of hypertension was 23.2%. The total participants here considered were around 7,467 participants. Moving to the variables that were statistically significant, we have age, people who are 45 years and above. We also have residents. All residents or all provinces were statistically significant. Anywhere you reside, you are at a risk of developing hypertension in Rwanda. Diabetic patients were also statistically significant. And also for the BMI, people who are overweight and are obese were also statistically significant. Those were the variables that were significant in my study. Concluding, as I just mentioned, the prevalence was 23.2%, which was higher than the national estimate of 15%. People who are 45 years and above, being diabetic, overweight, obese, And the residents, anywhere you reside, were found to be variable, which are at risk of having hypertension. As public health actions, these findings were communicated to the non-communicable diseases division in Rwanda, and they conduct regular population survey as they are essential to monitor hypertension trends and inform also the public health intervention. Particular attention was given to diabetic patients through education to understand the connection that can be between diabetes and hypertension. And also community-based intervention are conducted through community outreach with the help of health facilities that was established to increase awareness on physical activities and healthy diets. I acknowledge the following: the Ministry of Health, AFENET Rwanda, University of Rwanda, and the Rwanda Biomedical Center, especially the Non-Communicable Diseases Division. Thank you.
Thank you, Teta, and thank you for completing during the 5 minutes. Now I'd like to call
And I will be presenting the quality of management of adult hypertensives attending rural and urban primary health centers in Oyo State, Nigeria. Hypertension is a severe problem that has a huge risk factor on the non-communicable diseases. It is a significant cause of cardiovascular diseases worldwide, and thereby constituting a major public health menace. The prevalence is on the rise, unfortunately, and currently in Nigeria, this is about 29%. This varies across the globe, though. And the attendance at public facilities tends to be more in the urban facilities. About 55% of the populace do attend facilities in the urban sectors. In other words, the urban facilities have better patronage compared to the rural facilities across the board, in a situation whereby the population is even 55% in the rural settings. So we set out to look out for what is the quality of management of hypertension in these facilities, comparing the two strata, using the donor bidding model, which is a popular model to check the structure, progress, and outcomes. So we carry out this using a descriptive cross-sectional studies in 10 local governments in Oyo State, Nigeria. 5 of these are in the rural local governments and 5 are urban local governments. Among 460 healthcare workers and 460 hypertensives in 100 primary health facilities. So we surveyed availability of treatments, adequacy of number of healthcare workers, the perception of patients about the quality of care received, among others, using 3 different tools. So data was summarized and analyzed. So we found out that 91.5% of our healthcare workers are females, and their age, the mean age was about 44.6 years. For hypertensive, 80.2% of these are female as well, and about 94% of them have an age within 40 years and above. Now, concerning the personnel presence in our health facilities, we noticed or we observed that urban primary health centers have a slight edge over the rural facilities. The functional devices present at these health facilities was better or more in the urban facilities than the rural facilities. Generally, the community engagement of healthcare workers in these primary health facilities was poor. And also, training opportunities given to these healthcare workers was equally poor across the strata of health centers. Proportion of healthcare workers that responded correctly to the management of hypertension protocols were fair. However, patient knowledge of hypertension management was better in the urban center than the rural center. Patient perception of healthcare workers' information on blood pressure control was generally good. However, the counseling and education of patients was better in the rural primary health centers compared to the urban centers. Blood pressure measured across the strata was not significant. So we therefore conclude that there's no significant change in the protocol of management of hypertension in these 2 strata of facilities. However, we were able to observe also that there was a poor community engagement, reduced opportunity for healthcare workers for training, and there was a poor availability of basic tools for management of blood pressure. We therefore recommended that the primary health centers coordinators should engage the community more and, of course, prioritize patients' education. We recommend that the State Ministry of Health should provide more devices for the management of hypertension in these facilities, as well as that they should improve on training. Public health action was to discuss with the head of facility on the training and be disseminated to State Primary Health Care Board.
Thank
we
you.
acknowledge these institutions.
Well,
thank you.
A round of applause for him. I apologize, I jumped the 3rd presenter, who is God bless, so now you can present. He's from Tanzania.
Dodoma from January to December 2022. As we all know, cancer has become a major non-communicable disease globally, and among them is cervical cancer, which rank 4th among women globally. And in Tanzania, cervical cancer is the common cancer among women, resulting into more than 6,000 deaths annually. So we need to have a strong surveillance system in order to fight this condition. So as a result, the government of Tanzania established the Dodoma Population-Based Cancer Registry in 2018. However, since its establishment, no any evaluation which have been conducted to assess this system. So we conducted this evaluation in order to evaluate the system attribute as well as the usefulness of this system. We conducted our evaluation cross-sectionally, and the Dodoma Population-Based Cancer Registry was random selected among 5 population-based cancer registries which are present in Tanzania currently. And we used the MMWR guideline to evaluate a surveillance system. We collect our data through interview, document review, as well as electronic database review. And for each system attribute, a specific indicator were developed. So our analysis was done using Microsoft Excel as well as AP-Info7 statistical package. Dear colleagues, this is our result. We found that from January to December 2022, 123 cases of cervical cancer were captured by the system against 150 target. And we found also this data from this system has been the key to the establishment of National Cancer Coordination Unit, which was not there at the Ministry of Health, and it was established in 2021. Also, data from this system has been used to, has contributed to the formulation of National Strategic Plan for Prevention and Control of Cervical Cancer in the country. In terms of representativeness, this system collected data in all 10 cancer diagnosing facilities in Dodoma, so it covered the whole region. And we found that among these cases which were collected by the system in 2022, 89% were squamous cell carcinoma, while 11% were adenocarcinoma. And around 20% of cases were below 45 years of age. On simplicity, we had 3 indicators whereby we found that 97% of participants who were interviewed, were 33, agreed that they understand case definition well, while 84% say that the process of sample collection for cervical cancer diagnosis was easy or very easy, while 80% of participants used less than 10 minutes to fill a cancer registry form. So this indicates the simplicity of using this system. On acceptability, all required monthly reports were submitted on time, and we found that 72% of interviewed participants were satisfied with monthly reporting. On terms of flexibility, we found that other cancer conditions have been integrated into the system, for instance, breast cancer. And on data quality assessment, we found that the system collected data according to international standard, that is the TNAME, staging, and ICDO coding system of disease. And this allows comparability of the information collected by the system. On completeness, we random selected 10 cases from the system, and we found that 71% of the required variable which were completed into the system. So the completeness was 71%. And we found that in timeliness, both facilities were able to send a report on time. In stability, we found that only 33% of fund which is required to run this system is provided by the government of Tanzania. So other fund is provided by other stakeholder. So we conclude by saying that the system performance was satisfactory, the system was useful, and provided timely data on cervical cancer. However, the system was simple, but its stability can be compromised by low funding from government. And also completeness of data was not 100%, and this highlights the need for further data improvement. And we recommended it to the Ministry of Health to increase internal fund, regular supportive supervision. And these are some of public action which were taken. Results were submitted to the Ministry of Health. Supportive supervision and mentorship was done to health facilities. And also, there was establishment of catalytic technical meeting for data quality assessment in the region. We acknowledge this institution, and thank you.
Thank you very much. Thank you for the presenters, because we are running late, and the moderator for the next session is putting some pressure on me. So.
My question goes to my Rwandan neighbor, Sore, and I just wanted to know that what is it with the eastern side that significantly showed lower hypertension compared to the rest of Rwanda? Thanks.
Your neighbor was? Rwanda. So any very quick question for God Bless from Tanzania?
Thank you very much to all our presenters, but particularly for God Bless. I think it would be nice for us to know what were your cutoffs, especially for the qualitative attributes. How did you measure as to whether they were acceptable or flexible? What were your cutoffs? Thank you.
Thank you. And finally, any question for Enoch from Ethiopia? Yes.
Okay, thank you, Mr. Enoch, for the presentation. I wanted to know why did you use the odd references while we have even the current like WHO 2023 report for hypertension?
Thank you very much. I apologize. We are running late, so I cannot take more questions. So Enoch, you can start to answer.
Okay, thank you for the question. I can see that some references like definitions and trends, if we use definitions, trends, they could be the same throughout the time. For example, I hope you are asking the question why use old references like 2013, 2014 and others. What I want to show there is the trend through that time, and the evidence is registered like that on that online site. That's why I use that old references.
Thank you.
I think you got my point.
Thank you. The next one, God bless, please.
Thank you, colleague, for your nice question, indicating that you are interested in your presentation. So the cutoff point for each system attribute was 8%, and you find this from a previous study which was conducted in Uganda. Thank you.
Do we have any question to Nigeria? No. There was no question for our colleague from Nigeria? You still have one question to make, so Enoch, you can answer. Who is missing? Yes. Yes. Mm-hmm.
Thank you for the question. For Faith, you asked about the factors. As shown in the results, the factors that were associated were the age, 45 and above, the BMI, the residence, and also being diabetic. There are also other factors that were analyzed, but they were not statistically associated, such as alcohol use, tobacco, HIV status, history of other chronic diseases, but they were not, in this study, they were not statistically associated. Regarding the residents, also answering the question about the Eastern, as I've mentioned, this is the limitation of the study. This was a secondary data that were used. And I think regarding that, maybe there is a need of further analysis to know why all the residents were all statistically significant. Yeah, thank you.
Thank you. Any final question for Olubenga from Nigeria? Yes, it's the last one. Sorry, I jumped. We are in pressure to finalize the program.
Thank you for the presentation. My name is David from Kenya. My question will be, given the proportion of female patients, it seems there was a higher proportion. Now, in your thinking, is it due to the health-seeking behavior of females, or is it that females are at higher risk?
Thank you.
All right, thank you very much for the question. In my opinion, I think it's because of the health-seeking factor that is responsible for it. Females tend to visit the hospital with any slight change in their health condition, whereas the male will sit back at home most of the times. I think that's responsible for the results. Thank you.
Thank you very much. A round of applause for all the 8 presenters for this session on non-communicable disease injuries and mental health. And now it's time to pass the micro to the next moderator. And thank you very much for all.
So, for those of you who have been interested in the epidemiology of HIV in Kenya, I think you can attest that it's been through quite a process. And so I want to take you through this journey with the lens of the viral load monitoring system. Exactly 7 years from now, the UNAIDS targets to have identified 95% of people living with HIV, have 95% of them on ART, and 95% of them virally suppressed. This is what we commonly refer to as the 95, 95, 95. So globally, we are at 86, 89, and 93. In Kenya, where we have about 1.4 million people living with HIV, the progress is at 92%, 78%, and 73%. And so you can tell that viral suppression is the lowest of the targets. So what is a viral load test? So this is basically a test that measures the number of HIV viral load particles per millimeter of blood. And it's the gold standard for monitoring HIV treatment. The goal is to have an undetectable viral load, and there are several classifications once a viral load test is done, ranging from low detectable levels all the way to suspected treatment failure. So the eligibility criteria, all people living with HIV are eligible for a viral load test, but there's specification for the different age category. For example, if you're aged between 0 to 24 years, we'll do a viral load at 3 months after ART initiation, and then every 6 months. So this journey for viral load monitoring began back in 2012, where we had one laboratory in the western part of Kenya, and at that point we had turnaround times of 22 to 25 days. And over the years, we've increased the number of laboratories that are testing for viral load, and currently we have 10 testing laboratories, and by 2018, we had a turnaround time of 7 to 10 days. So the objectives of this study, we wanted to describe the people living with HIV who've been monitored in the system from 2018 through to 2022. We wanted to describe the trend of viral load monitoring and assess viral load monitoring during COVID-19 pandemic. And finally, we wanted to assess the surveillance system attributes of the viral load monitoring system. So this was a cross-sectional study that used secondary data from January of 2018 all the way to December 2022. We collected data from the 10 HIV reference laboratory, and all people living with HIV who've been monitored within the study period were included in this study. We collected socio-demographic and clinical variables, and we defined viral suppression as viral copies less than 200 mils. We did aggregated means of viral load tests done per year with their corresponding standard deviation and a paired t-test between consecutive years. We did a Bonferrari correction for multiple comparison and also an interrupted time series analysis before and after COVID-19 pandemic. We used the CDC updated guidelines to evaluate for simplicity, flexibility, representativeness, acceptability, timeliness, and data quality. We had authorization to access de-identified data. So we had a total of 5.5 million records, and of this, around 166,000 of them were marked as invalid tests. And so for this analysis, we evaluated 5.4 million records, of which 69% of them were female. For the socio-demographic and clinical variables, we had those who are more than 25 years accounting for the bulk of the viral load tests that were done, and they had a viral suppression of 93. However, children who are between 0 to 14 had a lower viral suppression at 81%. Routine viral load testing was the most common justification for doing a viral load test. So this is the trend of viral load testing in Kenya from 2018 all the way to 2022. And so you can note that there's a severe dip in the year 2021, and it's actually significant at the reference p-value of 0.00125. This is the interrupted time series analysis for COVID-19 before and after. We announced our first COVID-19 case in March of 2020, and before that we had an increase in the number of viral load tests that were done, and immediately COVID was announced, we started having a decline. However, the p-values for both time bands were not significant. For the system attribute of simplicity, we wanted to see the ease of operation, and we could clearly tell how samples move from the facility with an elaborate sample transportation mechanism all the way to the reference laboratory, where we have a laboratory information management system, and this system then aggregates the data within the National AIDS HIV program, and it's available on a public website. For the system attribute of flexibility, we wanted to see how the viral load testing will accommodate HIV recency testing, which is also a function that is within the system. And you could see that there was an inverse relationship. And so this points to the fact that this system is not flexible. For the system attribute of data quality, all years had data quality gaps, and you can note that some of the gaps were missing age, erroneous ages of more than 120 years, missing gender, and variations in dates. I want to point out that the year 2022 had the most number of gaps. For the system attribute of timeliness, we noted that the year 2021 had a significant lap, and so you can see that the turnaround for 2021 was significantly higher and way above the target of 10 days. For the system attribute of acceptability, we wanted to see how the stakeholders were willing to use this system. And so we could tell that we were able to respond to 89% of the expected need. However, in 2021, we had a severe dip of 38% of the need. For the attribute of representativeness, we seek to find out if every county in Kenya had a reference laboratory that responds to their need, and we found that this was actually the case. So as a point of discussion, females actually contributed to the bulk of viral load tests that were done, and this is in concurrence with the prevalence of HIV in Kenya, where females have a prevalence of 6.6 compared to males at 3.1. There was low viral suppression in children, and this is actually in concurrence with previous studies that have been done. In the year 2021, we saw that there was a statistically significant drop in the number of viral load tests that were done, and this could be attributed to COVID-19. The system was relatively simple, representative, and broadly acceptable. However, there were data quality gaps that were more pronounced in the year 2022, pointing towards limited impact for any possible intervention. We also missed our objective on timeliness by more than 50%, and the system was not flexible. So as part of public health action, we have been able to disseminate these results to the laboratory technical working group, and we hope that the results of this finding can be used to prepare what we call the Kenya HIV viral load monitoring protocol that currently is lacking. I'd like to acknowledge the following. These are my references, and for those who would be interested in this presentation, I have a link to that. Thank you very much.
Ok, merci à Grace qui nous a fait gagner un peu de temps.
Thank you very much, Grace. We are now going to move on to the next presentation from Mauritania. That is Lam Mariata, investigating a measles outbreak in the refugee camps of Wilaya in Hod Shargi in Mauritania. Mariata from Mauritania, and it's my pleasure to present to you investigating a measles outbreak in a refugee camps of Wilaya and Hod Shagri in Mauritania 2023. We know that measles is a contagious viral disease caused by paramyxovirid. It is transmitted by air and respiratory means. It is extremely contagious and it is affecting and causing many deaths, especially of children. And in the country, measles has been widely eliminated, but some imported cases remain a challenge. Measles outbreaks in refugee camps are a problem for public health in Mauritania. So the administration health division notified a measles epidemic in 2022. An investigation was carried out to assess the scope of the epidemic. Our objectives of the study: investigate and assess the scope of measles outbreak. Specific objectives to describe the individual case characteristics, describe geographic distribution of cases, describe evolution of case numbers, identify risk factors, and identify the risk groups. In this region of Hodi, Sharge has a surface area of 182,700 square kilometers with a population of 588,000 inhabitants. It is a border area, it borders with Mali, and there is a lot of movement from the nomad population in this area. There's a Mbera camp in this area with a population of 61,000 inhabitants. The type of study was a cross-sectional study. The method, the study population. The measles cases were recorded at the health centers in the Hod Chargi health region. Case definition is a presumed case and a confirmed case. A confirmed case is one that is confirmed at the lab level. The methodology, techniques and tools for data collection. We use questionnaires and interview guides. Information sources included patients from the Mbera Health Center, data analysis and management using APInfo, and we carried out statistical analysis. Results, ladies and gentlemen. This graph shows the attack rate according to age group in March 2023. We have 0 to 11 months, then 12 to 59 months in the columns. This graph shows the attack rate of measles in the Mata site in the Wilaya zone. We see an attack rate of 1.8 in the refugee camp of Basiku, and then Timbera 0.6 as the graph was. These results show us the change in or evolution in measles cases in Wilaya from 2021 to 2023. It's not the first time that there's an outbreak. This is between 2021 and 2023. Distribution of measles cases according to symptoms. We have fever, but the most important symptom is cough, fever, skin rash. Discussion. The epi curve shows an evolution in a drop of cases and an evolution followed by an epidemic peak in 2022. The age group that is most affected with the attack rate is 12 to 59 months, followed by the age group of 0 to 11 months, with an attack rate of 3.2. The district outside Baskino, outside the Mbera camp, recorded measles deaths. Discussion. The vaccine usage in the region has reduced progressively over 2019 to 2021, and 98% were not vaccinated. Other factors regard the role in the occurrence of outbreaks, like the organization of an supplementary immunization campaign in 2018, and then there are outbreaks in neighboring countries like Mali, where there's so much trade and many refugees move, especially to come to weekly markets. Conclusion. The measles epidemic is confirmed in several areas with a high preponderance in refugee camps. The age group that is most affected is that of 12 to 59 months, and most cases were not vaccinated, that is 98%. Recommendations to the Ministry of Health: control the new arrivals by carrying out vaccination, especially in the camp, especially for children who are less than 5. Then training of staff on epidemiological surveillance to strengthen the completeness and timeliness of surveillance reports. And then organize immunization campaign in the trans-border districts. And then strengthen vaccine coverage in the northern zone through putting in place a strategy for the nomadic population. Strengthen coordination between the health services at the regional level to improve epidemiological surveillance. We also recommend that WHO and other partners support the Ministry of Health in implementing recommendations, especially deploying a team to participate in vaccine response and to carry out activities together with WHO in Mali, neighboring countries, to limit the spread of measles. Acknowledgements to AFENET and the
I am presenting on one of the preliminary results as title here of a collaborative national study conducted by the National Public Health Institute of Liberia, the US CDC, AFENET Liberia, and universities of Liberia and Hawaii. So this is my table of content. In Africa, COVID-19 pandemic has not been as devastating as in other settings with regards to mobility and mortality. As of yesterday, over 9 million confirmed cases and 175,000 of COVID-19 deaths were reported in Africa. Relatively, there have been low proportion of COVID-19 cases that have been severe or have resulted into death of hospitalization. COVID-19 cases in Liberia remain low. In March 2021, the rollout of COVID-19 vaccine began, and response strategies encountered were shortages of supplies, vaccine hesitancy, resource constraints in hospital and vaccination sites. Limited research has been undertaken to understand the epidemiology of COVID-19 in Liberia. National representative seroprevalence study has not been performed in Liberia. Therefore, we do not know the true incidence of SARS-CoV infection in Liberia. The SARS-CoV-2 national study is divided into two parts, which consists of two objectives each. Part 1 describes the behavioral characteristics and proportion of neutralizing antibodies among Liberians, while Part 2 focuses on the prevalence of seropositivity of SARS-CoV-2, epidemiological and clinical characteristics of SARS-CoV-2 using stool samples from previous studies. However, in this presentation, I will be presenting the objective 2 of Part 1, which is to characterize the different epidemiologic, social, economic, behavioral, and geographic factors influencing test and vaccination-seeking behavior among Liberians. Liberia has approximately 5.3 million inhabitants, with Monrovia being its capital city, and is also divided into 5 health regions, 15 counties, and 19 districts. We used a cross-sectional study design to achieve our objectives, and we also studied 3,220 Liberians aged and above. To achieve our sample size, we used a multi-sampling technique. At stage 1, we used simple random sampling technique to pick 1 county per region. These are Montserrat, Grand Cape Mount, Bong, Sino, and Maryland counties. We administered a structural questionnaire to household participants from April 30th to June 3rd, 2023. We conducted univariate and bivariate analysis using IRA software. We sought ethical approval from Institutional Review Board, and we also administered informed consent and maintained confidentiality. These are our results. We eventually enrolled 3,273 participants for this study. Participants had a median age of 40 with interquartile range of 28 to 54 years. 28.3% were in the age group 18 to 29, while females accounted for 54.3% among the respondents. 62.5% of the participants reside in rural areas, and 78.1% are employed. This slide shows the distribution of respondents from each county selected per region in our study. Interestingly, 4.9% of participants mentioned that they have never heard of COVID-19. Of this percentage, 70% of them resided in Bong County, which is largely a rural area, and 28% live in Montserrat County, which is also largely an urban area. For awareness, statistically significant findings show that those who have males and were married were more likely to be aware of COVID-19. Subsequently, our analysis and results excluded the 159 participants who had no knowledge on COVID-19. Respondents who were tested for COVID-19 were 2.4%. 86 of them received their test results, and 2.9% were positive for COVID-19. 6.7% among those who were tested for COVID-19 reported paying for their test results. Of the 75 respondents that reported history of testing, 53.3% tested because they just wanted to get tested, and 14.6% indicated feeling sick at the time of testing. Respondents who reside in rural areas and have formal education were more likely to be tested for COVID-19 among our respondents. Concerning history of vaccination among our respondents, those who are 50 and above, who are residing in rural areas, who are married and are employed, are more likely to be vaccinated for COVID-19. Geographical distribution of the vaccination coverage among our respondents, it ranges from 47.1% in Monserrate to 85.6% in Grand Cape Mount. Now, let me bring to your notice that our national coverage in Liberia for COVID-19 vaccine is 85%. The majority of the respondents constitute the younger population, which is the representation of Liberia demographic distribution, where the age group 18 to 29 accounted for the highest number of respondents. This finding was seen contrary to a study conducted in Nigeria 2020. It was also recorded that a very low proportion of the study participants are not aware of COVID-19. This is because the Liberia has prioritized race communication and community engagement effort. We also saw this finding similar to a study conducted in Saudi Arabia 2021. Though educated people in the rural areas were more likely to be tested in our study, this could be due to low penetration of internet connectivity in rural areas, thereby reducing influence of misinformation during social media. Testing among respondents was relatively very low, which could be also attributed to fear of being stigmatized for having COVID-19 if confirmed. However, this study also aligns with a study conducted in Nigeria in 2022. Our study also found that association between social demographic factors and being vaccinated for COVID-19, this could be because in the rural areas, the community leaders, also known as vaccine champions, could easily influence compliance during vaccination campaigns. In conclusion, these preliminary results I've just presented shows a low proportion rate of testing despite vaccination coverage is also high. It also shows that those living in rural areas seem to have better testing and vaccination-seeking behavior among Liberians. Although these results are not available, it's still preliminary, it is also important that the MOH alongside her partners conduct additional investigations to determine if the study areas with high testing and vaccination proportion benefited from the additional COVID-19 intervention. I mean, for example, the EPR campaign that is ongoing. There were lessons learned from this study from collaborating with multiple stakeholders involved in the study, radio dissemination of race communication and community engagement messages, and involvement of surveillance officers at the sub-national level for data collection. I would like to acknowledge the few institutions that collaborated with AFENET Liberia for this study, and these are my references. Thank you for listening.
Thank you very much. We are unfortunate 2 of our presenters didn't make it, so we have only one last presenter who is going to be invited by Joseph. And I want to thank the first 3
Uganda Public Health Fellowship Program in Uganda, which is an advanced field epidemiology training program. I'm presenting to you a study entitled Rift Valley Fever Outbreak in Sembabule District, Uganda. That is in December 2020. So Rift Valley fever is a zoonotic disease caused by a virus, and it was first identified in 1931 during an epidemic excuse me, among sheep on a farm in the Rift Valley of Kenya. And it is transmitted by infected mosquitoes and blood-feeding flies, contact with the blood or organs of infected animals, ingestion of unpasteurized or uncooked milk from infected animals. And the human-to-human transmission has not been documented. Rift Valley fever infection can cause major economic losses due to high mortality rates in young animals and abortions in pregnant females. Abortion storms in animals often precede human outbreaks of Rift Valley fever. The incubation period in humans varies from 2 to 6 days, and symptoms range from a mild flu-like illness to severe hemorrhagic fever, which lasts between 4 to 7 days. And due to its varied and non-specific symptoms, clinical diagnosis is challenging, especially within the early stages of the disease, and only laboratory testing can provide a definitive diagnosis. For mild human cases, which are often of a short duration, no specific treatment is required. However, severe cases require general supportive therapy. On the 10th of December 2020, the Uganda Virus Research Institute was notified the Public Health Emergency Operations Center of the death of a 25-year-old male who had tested positive by a reverse transcriptase polymerase chain reaction for Rift Valley fever. Then on the 8th of December 2020, his symptoms included unconsciousness, difficulty breathing, red eyes, bloody urine, bleeding from the nose, and as well as the injection site. And the patient died on the 9th of December 2020. That is the map of Sembabule district. Map of Uganda showing the location of the outbreak, which is Sembabule district. So epidemiological investigations were carried out from 19th to 22nd of December 2020 in the patient's home district of Sembabule by a team from the Ministry of Health and Sembabule district officials. And the objectives of the investigations were to establish the scope of the outbreak, determine exposure factors for transmission, and institute control measures. So for the human case definition, a suspected case was defined as acute onset of fever or auxiliary temperature of greater than 37.5 degrees Celsius, and 2 or more of those symptoms, including headache, muscle or joint pain, unexpected bleeding, and any gastroenteritis symptom in a residence of Sembabule district from 1st November to 31st of December. And a confirmed case was a suspected case with lab confirmation by either reverse transcriptase polymerase chain reaction or demonstration of serum immunoglobulin M antibodies by enzyme-linked immunosorbent assays. Then for the animal case definition, a suspected case was defined as any domestic animal, could be cattle, sheep, goat, with any past history of abortion. And a suspected case was defined as lab confirmation by detection of antibodies against RVF virus using IgM ELISA, which demonstrated recent infection as early as 6 to 7 days post-infection. To find cases, we conducted interviews with other herdsmen and family of the deceased. We reviewed medical records and also conducted key informant interviews. Lab investigations were done and 8 blood samples were taken from the other herdsmen. 55 blood samples were taken from cattle, including 30 from 2 herds, herds A and B, that the case patient had taken care of, and 25 additional samples from 2 herds, herds C and D, which were located nearby. IG ELISA was performed on both human and animal samples, and IgM ELISA was performed only on the human specimens. 2 persons were affected and we had 1 death. There was 1 suspected case and 2 confirmed cases, and the case fatality rate was 50%. So you can see the timeline of key events for case A, and this we created by having an interview with the brother. So as you see there, the index case, the symptoms were began on 28th of November for the case A. And then on 2nd December, he traveled to visit his brother in another district, and his condition was worsening. So on December 3rd and 4th, he presented to health facilities, and they found that he had malaria, but he did not respond to the treatment. And then on December 8th, he started having difficulty breathing, bleeding from the nose and mouth, persistent hiccups, and he was rushed to another health center. And when he reached another major health center that we have in the country, he was admitted into the ICU and his eyes had turned red. So on December 9th, a sample was taken from him and sent to the Uganda Virus Research Institute. However, he died on the same day. And on the 10th, his sample was positive for RVF by polymerase chain reaction. The interview with his father showed that he was a full-time caretaker of a herd of cattle that big, and his major activities included grazing the cattle, milking, and spraying for control of ticks and other pests. He didn't participate in slaughtering, nor had he handled abortus in the week before his onset. And one of the 8 human samples was Ig and IgM positive. Case B was also a 25-year-old male herdsman who had no symptoms. He reported that he had not slaughtered or butchered any animal or handled abortus in the week before case A's onset. Then apart from the deceased, no other respondents had signs or symptoms of RVF. And neither of those that handled the animals or their products, none of them used protective gear. Both case A and B ate meat. Case A and 6 other respondents drank and boiled milk. Neither of the cases had direct contact with the wild animals during that week. Case A had been sleeping under a mosquito net, and all the 7 herdsmen who were at least involved in some activities known to be risk factors. The mean age of all 55 cattle sampled was 3.8 years, and that was the range. 96% were females, and all were crossbreds on a free-range production system. 51 of the cattle were healthy, and 4 were unhealthy. And of the 53 female cattle, 14 had a history of abortion, and animals were reportedly sprayed regularly for ticks, and no ticks were observed on the animals. Among the 55 animal samples, 29 were Ig positive. Of the 29 positive cattle, 1 was male, and of the 28 Ig positive females, 11 had a history of abortion. Environmental investigation showed that there were some domestic animals in that home, and there was charcoal burning that was happening, which shows that there was logging going on near the grazing area. So the cattle herders are known to be high-risk group for RVF in Uganda, and both probably interacted with animals. Both were males, and abortion among their cattle could have been a missed signal, and the case patient who died had a delayed diagnosis. None of them used personal protective equipment, and we identified possible logging in the area. Yet mosquitoes are known to be risk factors. In conclusion, an RVF outbreak in Sembabule district was likely facilitated by a close interaction between infected animals and humans, and we educated the family of the deceased. We recommend a district-wide serosurvey and surveillance, animal vaccination, community education on preventive measures, and RVF surveillance is important in Uganda, and we need to increase the index of suspicion among our clinicians for viral hemorrhagic fevers. Those are references, and acknowledge those people. Thank you.
Okay, merci beaucoup. Et merci à tous les
Thank you to all participants.
Thank you so much to our able presenters. You did a good job, both technically but also on time. You made me proud as the timekeeper. Nobody went beyond their time. So in the interest of time, we're supposed to have our tea break at 10:10 and then be in for our plenary at 10:40. We're doing well with time. We're going to take questions, but I request that we limit those questions and spread them across so everybody gets a question. Not more than 2 questions per presenter, kindly, so that we can make it on time for the next session. So I open the floor for questions. We are not going to teach them. We are going to ask for clarity, and we are going to be brief. Thank you. Yes. You can share this. It's not...
Okay, thank you very much. Resident advisor from Burundi. I've got 2 questions, one for Grace and the second one for Lam. Grace. So to what do you attribute the low uptake of viral load test in 2022 compared to 2019? Alam, quelle stratégie spécifique
What strategy do you propose to increase vaccine coverage amongst the nomad population?
Please walk in front to the mic, because we have only this. Please walk to the mic in front for the questions. And I know that might limit the questions if people have to stand up. But please come.
My name is Boku from Kenya. My question is to Frida from Uganda on an outbreak of RVF. My question is, you said, which is almost always the case, that an outbreak of RVF first starts in animals and then later in humans. What recommendations do you have in terms of surveillance so that for early detection and early response? And then on testing, you said all the animals were only tested for IgG. Why didn't you do IgM so that you can see if it's current infection and probably advise on the strategy to control?
Thank you.
Merci, bonjour. Mon nom c'est Moussa.
I am Musa from Niger. My question is for the last presenter. Why are there fewer cases?
So thank you very much for that question, and thank you for being attentive in our presentation. I agree that in the year 2022, we still have not achieved the target viral loads that we're supposed to do. But in addition to COVID-19 having contributed to a dip in the number of viral load tests that were done, there was a report that was done by Global Fund that confirmed what we were seeing on the ground, because we did not have commodities also to test for COVID-19, and this was also exacerbated by COVID-19 itself. Thank you.
Thank you so much for your questions. In Uganda, we've been having a lot of sporadic outbreaks of Rift Valley fever. And normally, what alerts us is the death of someone, which is so unfortunate. And the surveillance has a weakness in that the animal section is not really detecting the cases early. Because when you see these abortions occurring frequently, we should have already sensed that something is wrong and then found the cause so that we protect the human being. So what we are doing currently in the country is to improve the sensitivity of the farmers, educate them, the veterinary officers so that they are able to identify these things and then report. There's still gaps, but then it's work in progress. Then about why didn't we do IgM to determine current infection? I really don't have an answer. To be honest, I'll have to find out from the lab people that did the tests. And we had fewer cases because normally you realize that there are a lot of differential diagnoses for Rift Valley fever because of the non-specific symptoms. It's almost like malaria. So most times the clinicians, when someone doesn't respond to the treatment, the fever doesn't respond to the malaria treatment, that is when we go ahead to do the testing for RVF. So that is why one of my recommendations is to increase the index of suspicion among our clinicians. Thank you.
Merci beaucoup, docteur, pour la question qui m'a été.
Thank you very much, Doctor, for the question you asked. What strategy have you put in place to improve vaccine coverage in this area? The Ministry of Health has organized an immunization campaign for the border regions. We also adopt a fixed and advanced strategy for immunization for these populations, and that's what has been carried out. Thank you.
Let's take the next set of questions, please. I'll walk to the mic if you have a question. And if you can't walk, I can share my mic with you. Why don't you take that mic?
Yes, I would like to know did you involve the One Health approach in your investigation? This is the question for Frida. Thank you.
As we wait to take on the next question, kindly move to the, please. I can help.
Yes, thank you. Merci beaucoup. Je voulais poser
Thank you very much. A question on COVID-19, the COVID-19 presentation. I see that there was a problem in the zone that was hard to reach in terms of communication and vaccination, maybe a rural population or something. What have you suggested as a strategy for this group so that the public health measures are more effective?
Has made tremendous efforts in the One Health approach, and for this particular outbreak, we involved the different ministries, Agriculture and Ministry of Health. So when we went down to the district level, we worked with the district veterinary office, the district health office, and we had a veterinary officer move with us to collect samples from the animals. And then for the humans, we also had a clinician, a lab specialist to take samples from the humans. So we worked together and we shared information. Actually, I remember we were at some point, we needed to take some blood sample from the brother of the deceased, and the laboratory person from the human health sector had not arrived. So we had him, he was taking samples from the animals, and we requested him to take a blood sample from the brother of the deceased, and he actually did. So the brother of the deceased said, I mean, we are all humans, and I believe he can do a good job. So he withdrew animals from the animals and also withdrew from the human being, which was quite impressive. And we always try to work together. And we gave our findings to the Ministry of Agriculture as well, so that the surveillance can be improved in the sector. Thank you.
Thank you, Frida. Faith, there was a question for you. And if we have any other questions, please move to the mic.
Thank you so much for this beautiful question. So your question states problem in the hard-to-reach zoo and strategy for this group so public health measures are more effective. Okay, so we actually really didn't have hard-to-reach zoo because the presentation states that those that are in rural areas, they are more likely to be tested and also more likely to be vaccinated. However, the race communication and the community engagement efforts that were made actually help these people. So also from the presentations, the community leaders who are also called vaccine champions, they actually carry out all of these RCCE messages around. So doing campaigns, it actually helped to increase vaccination coverage. Thank you.
Thank you. We still have 3 minutes. Please. What are you saying? Were you just waving at me? Okay. Do we have any more questions? Okay, I think you did a good job. I need to clap for you. Everyone, and this, I think, marks the end of our session. So we can go for the tea break and
all of you to this session, and we apologize for the delay. It's not our fault. We have to wait for the plenaries to be completed before we start. So based on that, we were a bit delayed. On that note, I also want to appeal to you that one of the presenters has almost 2 presentations that are almost colliding. So we want to start with him, that is Richard Sefunon, just to break the rules a little, with your kind permission. And Richard is presenting on référence des cas graves de paludisme, et facteurs associés à la létalité chez les enfants de moins de 5 ans, département de Collines, Bénin, 1er avril ou 31 octobre 2022. Richard, you're welcome.
C'est ça.
D'accord, tu as 5 minutes.
D'accord. C'est bon. OK. Chers évaluateurs, messieurs, madame, bonsoir.
Dear evaluators, ladies and gentlemen, good evening. I am Richard Sefunon.
Sur la référence des cas graves de paludisme.
I'm going to talk about the referral of severe malaria cases and factors associated to fatality among children under 5 years in the Department of Colline, Benin, 31st October 2022. Malaria is a disease caused by the Plasmodium parasite. It has remained a major problem, major public health problem. In 2021, according to WHO, there were an estimated 247 million cases of malaria in the world, and Africa registered 95% of these cases. In the Benin annual report, there were 2,956 deaths in 2022. So we try to investigate malaria. Our methods, we carried out a cross-sectional analytical study. Our sampling was random sampling, and we collected our data from medical records. We collected demographic data. We analyzed this data and we calculated the frequencies of other ratios. We used the software for our case study. Our results: 403 cases were identified during this study. The demographic characteristics, and then we had 53% came from the rural areas. Monthly evolution of cases, there was an increase in cases from April to October in this area, and this was the most significant peak was in August. Danger signs that were met were anemia, convulsions. Fatality was 5.21%. The referral of 6.95 cases were referred, and these were taken by motorcycles, and then 46.7% had to use artesunate, and others suffered from breathing difficulties. Conclusion: severe malaria occurs amongst children of 12 to 36 months in the Colline area of Benin. The referral of severe cases does not follow the norms. Some factors associated with death, but it's important to have a better medical management to reduce fatality of severe malaria. We thank our ministry. And these are the references. I thank you.
Let me ask if Stephen Aricha is around. Do we have Stephen? No. Do we have Arnold Wilfred? No. Alice Asio? Egar Sotire? Egar? Okay. How about Messi?
Do you have Messi? And Mari is out. How about Edward? Edward Hunto Hotegbo. Ferima is here. Okay. Okay. Ferima Nikiema is presenting on analyse des données de surveillance. Analyse des données de
Analysis of epidemiological surveillance of yellow fever in Burkina Faso 2017 to 2021.
L'analyse des données de surveillance.
Present you results on data analysis of yellow fever epidemiological surveillance from 2017 to 2021. The yellow fever is a severe hemorrhagic with a plan to control yellow fever in the country. Burkina Faso is a landlocked country surrounded by Cote d'Ivoire and other countries like Mali. It is subdivided into 13 regions, 70 health districts within the country. We carried out a descriptive cross-sectional study on epidemiological surveillance data 2017 to 2021. Data analysis was done by Excel and AP software. All the suspected cases were recorded in the
Seems we didn't have most of our presenters here. Is there anybody here that is supposed to present? Your name? Say again. Name, say again. Derek. Is it room for ID? I can't find that name here. No, I'm talking of this session, I mean. So I think we only have this one from Kazakhstan. What's the name again? Okay, come on. Come on. We'll look for it. Search for a presentation.
Can
you help, please?
But I can find my.
What's the name again?
Malika Gabdulina is here. Yeah, I will present.
Okay, good afternoon. Malika should be presenting, but Saya is here to present on his behalf. That is outbreak of Crimean Congo hemorrhagic fever in Kyzyloda region in Kazakhstan, March to July 2022. Go ahead.
Good afternoon. Okay. Crimean Congo hemorrhagic fever is a viral tick-borne disease, usually carried by ticks. CCHF has a high mortality rate. Kazakhstan is located in Central Asia, and CCHF is considered endemic. From April to July 2022, samples from farm and domestic animals for PCR testing. Our case definition was a confirmed person was anyone hospitalized with a positive laboratory results who lived in the study region between April 13th to July 27th, 2022. A probable cases was a person with fever, at least one CCHF symptom, and who had known exposure to tick or tick region. A suspected case had the same criteria, but no known exposure. We used logistic regression to assess factors associated with being a case. We identified 38 cases, of which 15 were confirmed, 7 were probable, and 16 were suspected. 4 patients died. Mortality rate 27%. We recruited 71 controls. Cases peaked in end of June and early July. Most common symptoms were weakness, headache, and fever. Case patients' average age was 45 years. Cases were predominantly males, 74%. Those who became ill in 47% of cases were engaged in farming, and 37% of cases in gardening. The difference was statistically significant. Education in 53% of patients and 32% of contact patients in medium special. In adjusted multivariable analysis, we found that tick-related exposures were associated with highest odds of CCHF. Other risk factors, including being male, animal husbandry, and crop production. We tested blood from 55 controls. All were CCHF, PCR, and IgM negative. Only one was CCHF IgG positive, which indicates a previous infection from 4 months to 5 years prior. Of 163 ticks collected and tested, one sample of PCR was PCR positive for CCHF. Among respondents, 55% had not heard of CCHF. 14% removed ticks and gloves, and 4% sought medical care after contact with ticks. Improved awareness of prevention of exposure to tick CCHF, associated risk factors, and importance of seeking early treatment is needed. This can be achieved by raising population awareness of CCHF and on the ways to prevent a tick bite exposure in humans and animals. Educating healthcare providers can help with rapid detection of CCHF and reduce morbidity and mortality. Thank you.
Thank you very much, Saya. That was a good presentation. Do we have Maureen Katosimi from Uganda? Maureen? We don't. Okay, let me just go back quickly again. Do we have Stephen around? Do we have Arnold Wilfred? Alice? Is Alice around? Edgar Sorti? Mercy? Okay. Do we have Edward? There is no Edward. How about George Passy? Okay. Then thank you very much. I think this is the whole lot we have that are present for the presentation. On that note, I just wish to request for questions for the presenters. And please be brief and get close to the supporters with the mics, yes. Okay, you can get closer to the mic here if you have any questions. Please come over. Thank you.
Thank you, all the presenters, for your good presentation. I will ask from the order, from my friend, first from our brother from Benin. Now that for malaria, we are moving towards eradication of malaria, and you still have higher prevalence of malaria. Apart from treatment, do you have other interventions you are using to make sure that by 2030 we eradicate malaria in Africa? Then another question to you. You talked about referring children using motorcycles. How is your referral system like in your country? Then another question for you. You talked about the death. The mortality is high. What could be the causes of those mortalities? Then our sister, apart from vaccinations, do you have other interventions you are using to prevent yellow fever in your country? My friend from Kazakhstan, did you find any association between human transmission and animal in your study? Thank you so much.
You understand? You got it? Okay. Yeah.
pour aller plus vite. Et nous avons trouvé que s'il y a des soins à administrer pendant la référence, ça, c'est un point faible qu'il faut corriger. Sinon, le système est fait de sorte que nous avons les ambulances, on peut les appeler et ils viennent chercher les cas normalement. La troisième question
has to do with the causes of that high mortality rate. Yes, we have realized that children with some comorbidities such as malnutrition, well, there is an association there. This is a risk factor, and I can give you the details in a report that we have. The fourth question regarding the dependent variable, that is the disease. So all the variables are detailed in the report, and I can give you that. And the level of knowledge of mothers in terms of the referral. Well, because we have come up with a study, but that study did not allow us to go and meet with the mothers so that we could go in the hospital to see what is happening. So we did not plan to go to the hospital, to the community during this study. So, but we think that later we are going to meet with the mothers in the community, and we shall have more information regarding their level of knowledge about the referral system. Thank you. Thank you, dear participants, for your questions. That shows that you have an interest in our presentations. So now you want to know whether immunization is the only means to control yellow fever. Well, we can say that it is not the only means to control yellow fever, because yellow fever is transmitted through mosquitoes. So we can sensitize the population on the use of mosquito nets, but we also can sensitize them about controlling, the stagnant waters that we have in our neighborhoods. Second question. Out of the 27 confirmed cases, 17 developed the disease. Well, immunization was not complete among those cases. That's why they developed the disease. Third question, after the basic database analysis, what are the actions for public health? Well, when we are carrying out a study, just to give it value, you need to make a list of actions of public health that can help people to actually understand and, take action. Last question. What happens with the confirmed cases? So what we analyzed our database. So we don't know anything about the confirmed cases. We just analyzed the database.
У нас выявлены связи между человеком и животным в плане того, что те люди, которые занимались, которые имели скот, у нас выявлена связь, то есть ассоциация с тем, что как фактор риска выявлен. То есть нет, у кого шанс...
Не совсем поняла, повторите, пожалуйста.
Имею в виду, что мы не тестировали животных, на лабораторное тестирование животных не было, но мы производили тестирование клещей. Эти клещи, они находились на животных. То есть у нас выявлены связи, шансы того, что быть больным, было больше среди всех, среди тех, которые неправильно обращались с данными клещами, а также те люди, которые имели скот, также они были в группе риска.
Это спрашивали. Хорошо. So I guess I did not translate properly in the beginning. So she says we did not test the animals themselves, but then there was a testing of ticks from the animals, and it's the same disease, the same tick-borne identified in the animals and humans. There were, in the associations, in the risk factors, there were factors that are found. The highest risk factor was among those who were contacting animals, like dealing directly, taking care of animals. So it was tested.
По второму вопросу, касательно выводов, могу в целом обобщить то, что наше исследование показало, то, что у населения в эндемичных районах, в эндемичном районе, то есть в Кызылординской области, очень низкие знания и отношения и практика к данном заболевании, то есть, допустим, 38% людей в данном эндемичном районе, да, они никогда не слышали о данном заболевании, хотя в этом регионе было 4 смерти было. Также, получается, и их отношения и практика были очень низкими.
38%?
Да, они не слышали о КГЛ вообще.
Это вопрос по действию мероприятиям общественного здравоохранения?
Нет, это вопрос насчет заключения.
So the second question was about the conclusion. The conclusion is that we found about the disease was identified in this region, and the knowledge practice towards CCHF was very low in the region. The region is endemic for Congo-Crimean hemorrhagic fever, and yet there was very poor knowledge and practice among the general population. And as a consequence, just the people were not admitted to the hospitals whenever they had symptoms. They were not really seeking their care.
По третьему вопросу, планируем ли мы создание эпиднадзора? Вообще по КГЛ у нас проводится эпидемиологический надзор. Он проводится на постоянной основе, и подаются отчеты снизу вверх, то есть еженедельно, ежемесячно, ежеквартально. Но у нас все-таки есть пробелы в плане нашей системы эпиднадзора, так как у нас мы не можем снизить количество случаев, так как у нас очень обширная территория и также низкие знания населения, также позднее обращение населения за медицинской помощью. Это все сказывается на повышении количества случаев в КГЛ.
So the third question was about the surveillance system for CHF. There is a routine surveillance for the Congo-Crimean hemorrhagic fever in the country, in the endemic regions, including this one. The issue is it's routine, it happens every year, and yet because it's routine, passive, the cases are growing, and the knowledge and practice among the population is very low. The cases are rising.
Так, касательно четвертого вопроса, действия общественного здравоохранения на повышение количества случаев. После нашего исследования были произведены такие действия, чтобы мы узнали о том, что у населения низкие знания, отношения и практика. После этого началась проводиться работа для улучшения их знаний, отношений и практики, то есть начали раздаваться брошюры, начались проводиться семинары. Это и раньше проводилось, но после этого начали более чаще это делать. Также касательно поздней диагностики, именно поздней диагностики врачами данного заболевания проводятся семинары для того, чтобы улучшить знания и настороженность вообще медицинских работников, именно клиницистов, инфекционистов. Для этого начались проводиться претесты и посттесты, чтобы узнать знания медицинских работников, а также улучшать и закрывать пробелы по их знаниям.
So the public health actions were implemented first because the knowledge and practice among the population was low. The National Center of Public Health started implementing the targeted trainings to strengthen the knowledge and change the attitude. The trainings were done in the past as well, but this were more targeted and for the areas with endemic, so that specific questions identified in the study were tried to be addressed. And the other thing is because they were, this outbreak was severe with little cases, and it really indicated that clinicians do not really expect Congo-Crimean hemorrhagic fever. That's why the delayed cases are coming as well. Diagnoses are given late. So the system, the public health system now is doing trainings for the clinicians, pre and post testing, and the trainings as well for the diagnostic and symptoms.
Еще хотела добавить, также есть пробелы в лабораторной диагностике, то есть у нас очень много вероятных случаев, но подтвержденных случаев, вероятность случаев составляет примерно только 22% в год. И сейчас проводятся такие мероприятия, чтобы улучшить лабораторную диагностику в плане улучшать техническое обслуживание.
And the last thing that was identified is this study, only 20% of probable cases were confirmed laboratory. The laboratory capacity is very low, and it's another issue that is addressed now, strengthening the bench training for the laboratories to diagnose the CCHF.
Thank you very much, Saya. Thank you very much, all the presenters that were available for this session, and give them a round of applause. I think this has been very interesting, and a lot of issues have been revealed, and I challenge the presenters to still go back and further continue their research in these areas and try to fill in those gaps that we have identified and are left there at this point in time. So that's my advice to the presenters, and thank you very much for listening. Now we need to have a photo. I don't know if the cameraman is around, with the presenters and the evaluator. Quick one, and then we disperse. We end this session for the next one now. My brother. So thank you very much. We have come to the end of this presentation. Now we're waiting for the next one. And thank you all. Have a good evening.
Hello? Hi. So, are we ready for the final session? Just some quick housekeeping. Our presenters here, by a show of hands, kindly. 2, 3, 4. Hey, 5. It should be more than that. It's okay, you can put down your hand. I've counted 5, and yet we should have 1. Do we have the rapporteur here for the session? And the evaluators? Because I don't want to start and you miss out on being scored. It will be unfair. You're the evaluator? Good, so we can start. Rapporteur? Any rapporteur here? Okay, so I'm going to do it rudimentary and record. I'll pass on. Okay, our rapporteur is here, right? Maurice, you're the rapporteur. Okay, I give you a minute and we start. So we are not doing quite well on time. Okay, we managed to catch up. So maybe we can finish a little early since there is only 5 presentations here. So our first presenter is Derek. Are you here, Derek?
Good afternoon. From Zimbabwe, I'm going to present on demographic and clinical characteristics of COVID-19. COVID-19 case fatality rate is estimated to be 2.5%. Zimbabwe recorded an average case fatality rate of 3.5% from June to August 2021, when the country was affected by the Delta variant. Kadoma City keeps a COVID-19 death list with an objective of estimating the COVID-19 case fatality rate and for surveillance as a predictor of epidemic waves. The city recorded a COVID-19 case fatality rate of 10% from September 2020 to August 2021, which was the highest compared with all the other towns in Mashonaland West Province. The case fatality rate was higher than the provincial and the national average. It is against this background that we analyzed the death to describe demographic and clinical analysis of COVID-19 death and to come up with preventive measures. A secondary data analysis of 129 COVID-19 deaths was carried out All the 129 COVID-19 death records were included into the study. The death list captures variables such as age, sex, date and place of diagnosis, comorbidities, history of travel, conduct, isolation, date of death, among others. Death occurred in 61% of all the males. 75% of the death occurred to those who were in home isolation due to lack of inpatient care and limited isolation facilities. The median age was 67 years with an interquartile range of 47 to 80 years, and the median time to death from date of diagnosis was 3 days with an interquartile range of 2 to 5 days. The main comorbidities were diabetes and hypertension, representing 45% and having a combined 90% of all the deaths. "98% of the deaths were not vaccinated. All those who were vaccinated were females. Vaccination coverage among the deaths were lower in the general population in Kadoma at 38%. Vaccination coverage among the deaths were lower than the general population in Kadoma, which was at 38%, and the national coverage, which was at 48%. Among the total individuals that were vaccinated against COVID-19 in Kadoma City, majority were females, who were 59%. We concluded that lack of inpatient care due to limited isolation facilities. We concluded that there was lack of inpatient care due to limited isolation facilities, and furthermore, monitoring of patients in home isolation was not consistent. Vaccination was low in the COVID-19 death as compared to the general population of Kadoma City. We recommended consistent monitoring of those in home isolation, especially during the first 5 days after diagnosis. COVID-19 vaccination to be scaled up, targeting the at-risk groups who were the males, the elderly, and those with comorbidities. Risk communication and community engagement on COVID-19 to be conducted, targeting the at-risk group. Mechanism for daily monitoring of patients was put in place, and vaccination was upscaled, targeting the risk group, the at-risk group, and COVID-19 awareness campaigns were carried out throughout Kadoma City. These are some of the references that we used. Thank you very much for listening.
Thank you very much, Derek. So our next speaker is Anna. Are you here? The floor is yours. You have 5 minutes.
Boa tarde, senhoras e senhores. Sou a Madalena Vasco, de Angola.
Good afternoon, ladies and gentlemen. My name is Madalena Vasco from Angola. I'll be talking about, therefore, following the COVID-19 pandemic in Angola, the number of laboratories carrying out the testing has increased. AFENET, with the support of CDC and the project EDF, created a program to assess the quality
and the panels were given by Smart Spot. These programs had as an aim was to ensure that laboratories testing SARS-CoV-2 would be of a quality internationally recognized. The laboratories were selected by the Ministry of Health. The Ministry of Health selected 12 laboratories, and the program proceeded with 10 of these laboratories. The 10 laboratories were distributed among 4 provinces in the country. All these laboratories were using equipment such as Abbott M2000 and Gen Expert systems. Smart Spot Quality used inactivated biometric materially. Before the distribution of these panels, AFENET provided training sessions prior to start of the first EQA cycle to ensure the successful DSS testing. Each DCS contributed 2 points out of the total of 8 points per panel. The panel scored and its corresponding percentage, performance, and panel outcome can be seen in the table below. As a result, we had the results of 2021. The panel had 3 cycles. In 2021, in the first cycle, we had 71% of the laboratories passed the external assessment. 29 did not pass the external assessment. In the third cycle, we have an improvement because 88% of the laboratories assessed passed the external assessment and 12% did not submit the results. In 2022, we had a different situation because we started seeing in the first cycle a number of laboratories that did not submit their results. 47% of the laboratories did not submit their results. 53% of the laboratories submitted their results and were approved. In the third cycle, the number of laboratories that did not submit their results increased. We had 65% of the laboratories that did not submit their results. 18% of the laboratories submitted their results and passed. In conclusion, we can say that this quality testing system allowed us to understand which laboratories were in compliance with international testing standards. AFENET was always present to support these laboratories. When we compare the year of 2021 and 2022, we saw progress because in 2022, we had a lot of laboratories that did not submit their data for testing. By then, in Angola, SARS-CoV-2 was not tested for people traveling abroad. It was no longer mandatory. And furthermore, the program faced challenges such as lack of reagents for the labs. We also faced challenges because some lab technicians were struggling to submit their results. For AFENET to assess the laboratories, according to assessment by the AFENET, the laboratories that were carrying out the test managed to improve their performance during this period. Thank you very much, all.
Petronila, are you here? None? So we need to make a decision. Do we take questions for them? Because that was the first group. Or do we go on since there were only 5 of you and then we take the questions at the end? That's okay? Good. Okay, Derek, are you here? Please, the floor is yours. Then next we'll have Abdullah Hassan. Are you in as Derek makes his way? Deborah, are you here? Okay, so you'll come after him. Floor is yours, 5 minutes.
Closed it.
Good evening, ladies and gentlemen. My name is Ochre Derrick, a graduate from Ghana Field Epidemiology and Laboratory Training Program. I'm presenting on analysis of community-led total sanitation surveillance data in Central Region of Ghana. By way of introduction, open defecation remain public health concern as over 600 million persons still practice open defecation globally. In Ghana and Central Region, 19% and 16% of the total communities are open defecation free. Because of this challenge in Central Region, community-led total sanitation, which reduced open defecation, was introduced in the region and beyond. Since its inception in the region, the program has seen a slow rate of achievement, and hence the analysis. We therefore set to assess the trend and distribution of open defecation communities in Central Region, to evaluate access to basic sanitation for the review period, and to assess the number of latrines constructed for the period. Secondary data analysis was employed. The site was Central Region. The analysis also focused on triggered open defecation communities and open defecation free communities. Data was then extracted from Regional Interagency Coordinating Committee on Sanitation Verification Data into Microsoft Excel and then cleaned. These are key variables analyzed. Data was then analyzed into frequencies, proportions, and presented as tables and charts. ArcGIS was used to generate map showing distribution of open defecation free communities. Figure 2 shows the trend of open defecation communities declared in Central Region. From the graph, open defecation free communities declared started increasing from 2017 to 2019 and then declined in the last 2 years. Figure 3 shows open defecation free distribution by district in Central Region from 2017 to 2021. It was clear that out of 22 districts in Central Region, 16 districts has been able to declare communities ODF. Table 1 also shows population with access to basic sanitation in Central Region. Over the 5 years, 63,407 population were sensitized or triggered to own latrines. Out of that, 34,755 were able to put up latrines, constituting 55%. Table 2 shows latrine coverage in the region. Over the 5 years period, 478 communities were triggered or sensitized to put up latrines, with a total household of 9,753. Out of that, 6,525 household latrines were constructed, constituting 67%. In conclusion, open defecation free coverage per district was above 70%. The highest open defecation free declaration was in 2019, and the lowest was in 2021. Little above half of the population triggered or sensitized. now have access to basic sanitation. Central regional latrine coverage falls short almost by 30%. These are the recommendations. All heads of the implementing district should consider triggering immediately in open defecation communities so that it will facilitate their declaration. The regional environmental health officer should ensure that there is collaboration between all stakeholders. The public health action, the findings of the analysis were shared to the regional environmental health office, and also the report was also shared with the district authorities for speedily implementation. I acknowledge the following stakeholders. Thank you.
A big hand clap as we have the next presenter, please. John, are you here? Mohammed, are you here? Please come.
My name is Deborah Ujo. I'll be presenting about a discrete choice experiment to predict factors associated with enrollment to a national health insurance scheme in Kampala, Uganda. So briefly, the introduction. Uganda is the only East African country without an operational national health insurance scheme. However, until March 2020, discussions were ongoing about a proposed national health insurance scheme, particularly about enrollment. This study set out to understand the importance of the different design attributes and the scheme trade-offs in Kampala, Uganda, to understand their enrollment. The methodology of this study, between January and March 21, a discrete choice experiment was conducted among 433 participants. This is the study map. The experiment was conducted in 2 phases. We had the qualitative component and the quantitative component. Under the qualitative, we did review literature and provide focus group discussions to understand which attributes will be adopted in the quantitative method. The quantitative method involved collection of data. We analyzed using a conditional regression model, and the results are as follows. So these are the results of our study. We realized, just a moment. Yes, we realized that 69% of the respondents were willing to take up a national health insurance scheme, and actually the men were more willing to take up this scheme. When you look at the factors involved, we realized that respondents preferred a national health insurance scheme that catered for annual contribution as well as a comprehensive scheme compared to monthly contribution and a basic health package. So the last objective of this study was to understand the trade-offs for enrollment. We looked at the average marginal effects to understand really the relative importance of the various. You can note from our results that the relative importance for providing a comprehensive health insurance scheme is 0.225 times that of a basic health insurance scheme. So what does our study tell us? Our study tells us that the scheme level factors have an effect on enrollment to a national health insurance scheme, hence the need to incorporate consumer preferences when designing and implementing a national health insurance scheme that will be acceptable by the public. We recommend a population-centered and inclusive health insurance scheme, and we also recommend exploration of scheme-related factors for each of the demographic groups to be included in this scheme. We also further recommend institution of a robust governing system for the proposed national health insurance scheme in Uganda. I acknowledge the School of Public Health, the co-authors who worked with us, the research team, and the study participants. Thank you.
Thank you, Deborah. Do we have Nelish? Okay, and do we have Mawuli? Okay, so you'll come up to him. Thank you.
Okay, so good afternoon, everyone. I'm Jambo. So I'm Nilesh Gopal from Mauritius, Frontline FETP, and I'm from Mauritius. It is a dot in the Indian Ocean, next to Madagascar, with a population of 1.2 million. So my field of work was leptospirosis because it is a zoonotic disease, mainly tropical, and it is transmitted by rodent and in contaminated waters, and the symptoms of fever, jaundice, and renal failure. Now, around estimated of 500,000 cases of leptospirosis are happening worldwide with a case fatality of 5 to 30%. And as per CDC, it is a underdiagnosed and underreported neglected disease. Now, as per the WHO case definition, so the suspected case are patients showing signs and symptoms, which I mentioned, and the confirmed case is laboratory confirmation, by a rise in antibody titer in consecutive samples or PCR detection. Since it is tropical, that's the interest in the study, and the aims of an objective is to retrospectively analyze the incidence of leptospirosis from 2017 to 2022 in 5 regional hospitals in Mauritius by time, place, and person. And to achieve this, ethical approval was sought from Ministry of Health and the Director of Lab Services, and data was collected from the leptospirosis database in virology department, and Epidata 3.1 and Excel was used for analysis, and the sample population for the 6 years was 221. Now the results as per time, we can see that there is a drop in the number of samples in 2020 with a high positivity rate of 6.2%. And the trend, it is suggestive to a problem in the year 2020. Now, monthly analysis, we can see that the highest incidence is found in the month April and May, followed by January and July. And the highest incidence was found in the south region of Mauritius, that is the Jawaharlal Nehru Hospital Regional. The south region is mainly this region. And the analysis by person is like 76% of them were male and 24% were females. And as per age group analysis, we can see that the highest incidence was 2.72% for an age of 50 to 59 years. Now the discussion There was an underreporting in 2020 because there was the COVID pandemic and restrictions and lockdown in the island was for 3 months. The high positivity rate in 2020 is suggestive to that there is no rodent control during the COVID pandemic. The month of January, April, and May are the month of rainfall and cyclones in Mauritius. Therefore, it is suggestive that the disease is seasonal. And the South region has the highest sugarcane fields hectare, which is like the high rodent population. And males and working age group is suggestive to profession-related tendencies. Now, as conclusion, there is a probable epidemiological link between the incidence of leptospirosis with the highlighted factors, and it needs to be investigated. Now, as recommendations, increased awareness and communication always helps. At national level, it was done at the FETP level via the Indian Ocean Commission and the CDCU. The serovar analysis will really help to determine the strain circulating in the island, and sensitization campaigns will help educate people about leptospirosis and its mode of transmission. Restrictions to affected areas would help, and because it is a zoonotic disease, the One Health approach is really necessary to involve other stakeholders such as animal health services and agro-industry. Now, public health actions that have been undertaken, the laboratory has optimized the PCR analysis for leptospirosis for rapid and early detection. The RPHS and CDCU are taking actions such as the rodent control in affected areas, and the hospitals, area health centers, and community health centers, we have noticed a slight increase in the number of requests. This will reduce misdiagnosis and underreporting. And at national level, leptospirosis has been considered among the 40 priority diseases in Mauritius through the IDSR, the Integrated Disease Surveillance Response, implemented by WHO and CDCU. So my acknowledgements goes to FETP, COE, and AFENET, and these are my references. Thank you so much. Asante.
Thank you very much. May we have our last speaker, Mauli? And as he comes up, the previous chair told me somebody had missed presenting. Are you in and ready?
My name is Mawali Guboho. I am a frontline alumnus of Ghana, and my presentation would cover the spatial distribution and risk factors associated with the Borreliosa disease in 4 endemic districts of Ghana. The Borreliosa disease is one of the neglected tropical diseases which continues to pose a significant public health challenge in Ghana, despite the decline in the incidence over the years in the country. And more recently, the application of geospatial information system has become very instrumental in identifying high-risk areas where interventions could be targeted. So it is based on these that we sought to explore how spatially distributed the cases were, as well as identify the risk factors associated with this disease. Now, talking of the 4 endemic areas, we conducted our study in the 4 endemic districts in the southeastern part of Ghana. And now, our study was carried out in 2 phases. So for the first phase, we performed a retrospective spatial analysis where we extracted 263 Borreliosa cases with their respective community coordinates, and then performed an average nearest neighbor analysis to identify the disease pattern, as well as the multiple ring buffer to assess the nearness of the cases to riverine bodies. And in the second phase of the study, we performed a community-based match case control study where we defined our case and control and matched 70 cases to 140 controls based on their age, sex, and their community affiliation. And so we performed a conditional multiple logistic regression to identify the factors associated with
the disease condition. So for our findings in relation to the spatial distribution, we observed that less than 2% of the cases were resident within a 500-meter buffer radius around the water bodies. And on my right-hand side, where you could see the average nearest neighbor analysis, showed that the cases we see on the left-hand side are significantly clustered. We observed a similar finding in the second geographical area with these two districts, and we could attribute this to the improvement in the local environmental conditions in these areas. Now, for the risk factor assessment, here we observe that individuals who farm with less protective clothing were at an increased odds of contracting the borreliose as compared to those who do not farm. And in Ghana, due to the hot weather conditions, farmers are more motivated to wear less protective clothing while participating in their farming activities in order to enhance their work productivity. And for persons who reported residing in an environment with riverine bodies, we observed that they were at a 5 times increased odds of contracting the borreliosa as compared to those who didn't report such. And in a Ghanaian study in 2017 by Aboagye and colleagues, a Microbacterium ulcerans organism was isolated in the soil of a BU endemic community located along the Denso River, which could put the individual at risk of contracting the disease. So, while considering a sound understanding of the limitations that secondary data analysis and case control could pose, would conclude by saying that the borreliosa cases are clustered, and that farming with insufficient protective clothing and residing near water bodies were risk factors identified. And so therefore, we recommend that the Health Promotion Unit of the Ghana Health Service educates community members on wearing more protective clothing during their activities. So through a community sensitization exercise we carried out in one community in the Jasikan district of Ghana, we were able to, this action actually led to the identification of cases where these cases have been linked to care. And so I would like to leave you with this message. Thank you very much.
Thank you very much. Just one final call. What was her name? The last presenter? Mary from Uganda. Okay, so I think we close out the presentations and we move to the question and answer session. So you've listened to very interesting presentations and happy to take questions. So we'll take a couple of questions, maybe 5, answer those, and then take another round. Do we have microphones? Okay, so kindly you move to the front, queue up so that we move pretty fast and redeem time. I'm sure everybody will be happy to break off early. Please, questions.
I was waiting for her. Thank you very much. I agree there were excellent presentations, especially hearing that some of you are frontline workers. 2 questions, one for Madeline. It may not have been clear because of the translation from Portuguese to English, but I thought I saw on your slide, okay, je parle lentement. I'll speak slowly so that the translation, is the translation coming? Português to English. Não fala português, fala pouco. It's okay? I thought on your slide you mentioned that the quality of the laboratories in 4 of the provinces went down from 2021 to 2022. Is that correct, or maybe I didn't hear correctly? And if it is so, why is that the issue? I thought that there should have been improvement from 2021 to 2022. My second and last question is to the other Derek from Ghana. You were talking about open defecation. I was just wondering, with such a high percentage of people still not having access to latrines, is there not a program in Ghana which is supported by the government or other development partners, even giving cement to ensure that there is a greater coverage for latrines? Thank you.
Thank you very much for the wonderful presentations. My question goes to the last presenter. You talked of using a case control study. I am wondering why you did a case control study, because I'm thinking a cross-section would have been much better. And then why you did do the study in an endemic area, because that's already known that they have the disease. So I don't know why you did it there, unless you saw some changes in the database that you had to go and check out what the issue is. And then how did you identify the cases and the controls, your inclusion and exclusion criteria? Thank you so much.
Thank you so much for the good presentations. I will start with the first presenter of the Kadoma City. You talked about the death that mostly they occurred in isolation centers. Before, in isolation, when people are waiting for results, what made you to make a conclusion is that they died of COVID other than other respiratory tract infection? My friend from Angola, would I be right to say that Angola did not have COVID-19? Because the way how you describe your laboratory, they were not able to detect, to carry out the quality control, assessment, and qualify to test for COVID-19. Would I be right to say that you didn't have COVID? And you later said it was not mandatory to do a COVID test when we are not moving out. So that one showed that you are not sure of what you are doing. Thank you. My friend from Ghana, you talked about the toilet coverage. After the intervention, you moved from 19 to 67. Don't you have laws to enforce people to have toilet? Because that is self-help. But you see, even your coverage is below the recommended one, WHO of 80%. Don't you have laws to enforce people to have good toilets, to construct toilets? Then, my friend Devola, thank you for the good presentation. Now that the discussion is for national insurance scheme is in place, what was the upgrade premium that everybody was comfortable with to be able to pay? Thank you. Then my last presenter. Thank you. What was the most affected age group of those people with rural ulcer? And what was the case fatality, if there was any? Thank you so much for the wonderful presentations.
Thank you so much to the presenters. And I have questions for Deborah. So I didn't fully understand what were you comparing with for me to be able to see what trade-offs was someone really taking. Were you comparing to the status quo? And what were the final choice sets that you had so that we see what marginal trade-offs were the people making? And then given the status, it's a stated preference method that you're using, it's not truth-telling. So how did you take care of that in compatibility in the responses so that we can know that this can be taken up by a policymaker? And then you had the attributes. I don't know what was the final, what design you used. Did you use the D-optimal design? Did you block so that you'll be left with how many choice sets? So how did you take care of the non-attribute attendance? And if you're dealing with insurance, I expect that there are non-linearities when they're thinking of the disease to be insured and the people and the population. So How do you take care of that heterogeneity in your study? Thank you.
Thank you, presenters.
I beg that we first answer the first set. Please just hold. We have time so that we give them liberty to be able to respond to those fully. Then we come back. Is that okay? Okay. So who would want to go first? I suggest that you go through all the questions addressed to you, and then we move like that.
Thank you very much, my brother from Uganda, for the question that you have posed. So in Kadoma City, majority of the death occurred in home isolation and not in isolation centers. The policy in Zimbabwe was severe COVID-19 cases were given first preference of isolation in isolation centers, and the remainder the rest would isolate at home. So this is where the deaths were happening due to inadequate care in home isolation, and also due to limited isolation facilities. And also the results of the study also showed us that the range of death among people on the death list was from 2 to 5 days. And this is where the monitoring of patients in home isolation was lacking. Thus, the high number of people dying in home isolation compared to institutional isolations. Thank you. Okay, sorry I had missed this one, but I'm just being reminded that there was a question on specifying the study design. We carried out a descriptive secondary data analysis of all the 129 COVID-19 deaths that occurred in Kadoma City. Thank you very much.
Obrigada pelas perguntas aqui colocadas.
Thank you very much for the questions raised.
Eu poderia que vou falar
I will try to speak a bit slowly so that to facilitate interpretation, because I believe that if I speak too fast, my message might not be well interpreted. The first question is about the quality of the laboratories. I think you understood that the quality of the laboratories reduced. The quality of the laboratories did not reduce. If you look at the graph for 2021, in the first cycle of testing, of the 100% of laboratories, 71% of laboratories passed. In the third cycle, we had a rate of 88% of laboratories passed, so the quality improved. The graph in 2022 is different because in 2022, a lot of laboratories did not submit their results. This because what happened in 2022 and 2021, we were testing travelers, contacts, suspects. We were testing a very large population. In 2022, we started easing the restrictions around COVID-19. So when I spoke about the travelers, it's because it stopped being mandatory to test travelers. Because of that, the number of laboratories that were testing travelers or testing for COVID-19 reduced. The second question is to say, the question was whether Angola had COVID-19. Yes, Angola recorded more than 100,000 cases of COVID-19. All these cases were tested and confirmed by laboratory. We're talking 100,000 positive cases of COVID-19. However, we tested a much larger number of people. What happened in Angola was that we started testing less people because we had fewer reagents, we had fewer laboratories doing COVID-19 tests, but up to now, in smaller amounts, Angola continues to test for COVID-19, especially for those who have symptoms of COVID-19. Thank you.
Thank you once again. My first question was, open defecation is a major challenge in Ghana, and what steps is being taken by government of Ghana to improve the situation? What I would like to say is that open defecation, especially managing sanitation in every sector, is very expensive. And government of Ghana is also doing what it takes to make sure the situation is calmed down. What I want us to realize is that most of the communities which practice open defecations are in rural setting, and they form majority of the communities in Ghana. And therefore, managing a situation like that, you need a multi-sectorial approach from stakeholders, other donor funding, and government of Ghana partnering each other so that the problem can be solved. In our subsequent recommendation, we recommended that government of Ghana should partner donor agencies so that the problem could be curtailed. The second question was, don't we have laws to enforce people to stop this menace? We have laws, or what we could have been done. Those who practice open defecation mostly are in rural setting, and most of them, their income status is very low, and therefore you cannot force them to put up latrines. You have to use another approach which has been introduced as community-led total sanitation, and gradually we are improving the system. Thank you.
Thank you so much. It's great to know that many people are following on. So let me run quickly through the questions. So my brother from Uganda was inquiring about the agreed premium. In this study, we did categorize the salary income to also the premium they were willing to pay. Interestingly, just about only 10,000 shillings, Uganda shillings, were actually what respondents were willing to pay. On top of that, they also preferred it deducted on annual basis. So that is also something to play around with. How do you get finances with that little coming in from the public? The next question was about the marginal effects and which exactly were they. Briefly, the comprehensive care package was one with the best marginal effects. That was about 0.2. It had the greatest marginal effects in the study. Payment modalities as well as the unit of enrollment had positive marginal effects. However, they were not quite significant for us to have them highlighted here. The next question was about originality versus it being a stated preference study. So in this study, we recruited about 433 participants. Our belief is that the wide data set provides for this. However, the study also went on to really probe for the respondents' ideas. So the beauty about a discrete choice experiment study, it allows us to also predict before it has come on. So I must say one of the limitations is about it being a stated preference. So we worked about it in that way. I think that was all for my side. Thank you. If I've forgotten, I could also pick it on later. Thank you.
Thank you very much for the question and for listening to my presentation. And for the first question on why case control study instead of cross-sectional study, despite the fact that we sought to address a problem, we also sought to improve on the methodological gaps that exist. There were previous studies that had carried this out using cross-sectional studies, but we thought it wise to go in for a case control study, a matched case control study. That is a 1:2 case control study. Why? Because the evidence has suggested that matched case control studies by 1:2 improves on the statistical power in detecting the associations between the exposures and the outcomes. And for why endemic areas, I think the mode of transmission for borreliosa continues to remain unknown, which means that in these areas we'll still have the burden of the disease in there. And so in 2019, the National Borreliosa Control Program highlighted the fact that there was inadequate knowledge of the disease within these areas. And so we sought to perform or carry out this study in this area to also contribute to that knowledge of educating them on the risk factors to try to minimize the incidence and the burden of the disease in the community. And for my inclusion and exclusion criteria, so our case definition was based on the probable and the confirmed case definition, and our controls were obviously those who do not show any signs of borreliosa. However, evidence has suggested that the incubation period of the disease is between 3 and 4, is an average of 3 and 4 months. So we ensure that when we enter the communities, individuals who met the case definition, but however hadn't resided in the environment for more than 6 months were not selected. Why? Because we wanted to ensure that they had been exposed to the environmental conditions so that it brings out a true reflection and representation. And the case fatality rate and most affected age group, we didn't assess the case fatality rate in this study. However, we observed that the burden of the disease was more amongst those 15 years and above as compared to what had been identified in previous studies. Thank you. I hope I have addressed all the questions.
Maybe before you move, you can take my question.
Okay.
Just help us appreciate what was your matching variable and why did you match to it?
Thank you very much. So, with respect to the matching of the variables, we utilized the age, the sex, and then the community affiliation. And our reason for matching was obviously to control for confounding, because age, sex had been identified to be confounders. And for selecting them within the areas, selecting the cases and the controls within the same community they come from was to ensure that they were all exposed to the factors within the environment. However, the difference in there was the outcome. Thank you.
Okay, thank you. I think we'll pick it up from there. I think some issues need to be fixed, but in the interest of time. Because when we match, in principle, when you match on a variable, then you don't study that variable. But you talked about age. You said the 15s and above were more likely. Then that becomes an issue. If you match to age, that shouldn't be it. Yeah. Yes, please. As the next set of people with questions, please stand.
Yes, thank you very much. So the burden amongst those 15 years and above I mentioned was from the retrospective analysis we conducted. So that is where the burden is coming from. Yes, thank you.
You go first.
Okay, thank you. Just a quick one. My question goes out to the presenter on leptospirosis. I would like to know more on this particular disease. I understand it's a neglected disease in your country. What's actually influenced your decision to actually conduct this study on this particular disease? What influenced you to actually go into this particular disease specifically? Thank you.
All right. Thank you so much. Thank you, our presenters. I have two questions to two different persons. The first is on the quality assessment. My name is Hyacinth Ebuna, from Nigeria. So the first is the quality assessment of SARS-CoV testing you did in Angola, which happened to carry out by External Quality Assurance Program. I don't know if there's any recommendation because it's a key for us to improve in our laboratory testing. So that is the question. So if you have, I would like to know because it will help me to understand better. Then the other one is on the Derek. So you mentioned about, I know you are trying to assess the latrine. I think it's very, very important for open defecation. What about population of people that doesn't have latrine? Because that is, we help us to inform the recommendation, because for us to improve in our public health activity, there should be a recommendation, and action must be taken so that our data can inform the decision. So I don't know if there is that particular population with latrine. I know your objective, but that will help us to understand better. I mean the population without latrine. Your data, you're speaking mainly on population with latrine. So you're studying about population and population with latrine. So what about population without latrine? Within that, your study area. I don't know if you understand me.
It's okay. So you're asking him to tell you what percentage of the population did not have latrines. Yes. That's the question? Yes, you didn't get that. Have you got it? Thank you.
Okay, thank you very much to all the presenters. Just adding on to my brother from Mauritius, I want to find out whether currently you have pest and rodent control activity in your country, and if you haven't started, whether you add it as a recommendation. Thank you very much.
Thank you to all the presenters. It was very interesting. I have one question for my colleague from Mauritius. You mentioned that the cases of lepto, they are under-notified. So what are the recommendations that you suggest to reinforce surveillance in Mauritius? And how is the response carried out following the detection and the confirmation of a lepto? So it comes with the question of the previous one concerning the rodent control unit and concerning the One Health approach towards controlling lepto. Thank you.
Thank you all our presenters for enlightening presentations. So my first question goes to our colleague from Angola. So I will speak slowly so that we can be able to pick the question. So you investigated on the lab quality indicator for proficiency testing. I did not see any results for the turnaround time and the rejection rate. These may have an effect on why the labs were not responding were not giving response for data in 2022. And then my other question goes to the colleague from Zimbabwe. What was the quality of the data set, and also what were the positive changes that may have been done due to the study that you, or the public health, if the public health actions that you may have recommended in your study? Thank you.
Okay, I think that you want to take one, Prof?
Yeah, just on the last one.
Oh, okay, you'll have the flow, and then we answer.
No, I want to thank the presenters for the good presentations. I didn't want to talk, but I had to. Not because of what Sheba said, but because I think we're seeing some progress in you trying to do studies, come up with recommendations, and key public health actions. So maybe the question I'm going to ask will apply to each one of you, that when you're making a recommendation, you should be able to quantify things. In Ghana, if I would ask you, what's the cost of building a latrine? So that if I have a bit of money here, I can say, okay, let me contribute 10 latrines in Ghana. That's one. I hope you can answer that. And the second thing is that we always believe that if you go to a village and they're practicing open defecation, they're happy, they are doing it. Do you ask them whether they're not happy doing it? Would you ask them what they would try to give up by taking the latrine? I think we need to do those things. Because you can go with your intervention and 70% are still doing it. So that is important. And my brother here with the Bueli ulcer, you also recommend the use of protective clothing. How much does it cost? Do you know? It's very important to cost whatever you are recommending to government, so that you can appreciate it. But it's only taking $1,000 to do this. Why are they not doing it? Or it's taking $1 million. So that's the question. I hope you can attempt to do it.
I think so.
Okay, thank you very much, colleagues, for the questions. So the first question was on quality of data of the data set. So data quality was one of the limitations to this study. We failed to assess a key variable that we wanted to assess, that is date of onset of signs and symptoms, due to the fact that completeness was at 23%. However, we ended up assessing number of days to death from date of diagnosis. So this was one of the challenges on our data quality. However, all the other variables that were assessed were 100% complete. And the second question was on the changes that were brought about as a result of this study. So firstly, we improved on daily monitoring of COVID-19 patients, and patients were being monitored on the first 5 days, either by phone or physically. And this gave rise to telemedicine, which is also now being used to some other services in the health sector. And before the study, we had one 14-bed isolation facility with 7 beds for male and 7 beds for female. But after this study, we identified and established a 60-bed isolation facility with 30 beds for males and 30 beds for females. We also embarked on a vaccination campaign, and we conducted what we called moonlighting, a strategy that we borrowed from the HIV program, whereby we would follow the males who were part of the at-risk groups to their recreation facilities, such as the BROs, at the end of work, and then we would conduct our vaccination campaigns in their places of recreation. And we also visited their places of workplace. The area is ripe with artisanal miners. We also visited them in their mining areas, and we advocated for COVID-19 vaccination. So these are some of the changes that occurred as a result of the study. Thank you.
Vou aguardar que coloquem os fones. A primeira questão, e obrigada pelas questões colocadas, eu acredito que quer perceber como é que funciona esse programa de avaliação para aprofundar.
And how this program works, correct? AFENET regarding the external evaluation of the SARS-CoV-2 test contracted a South African company.
Recommendations, I mean the recommendation from the program, the quality assessment. That is what I asked.
Okay.
Thank you. Regarding the recommendation, why it wasn't presented here? It was a limited program, it was a finance program, and it was limited funding. So we could recommend the Ministry of Health to continue, but I'm not sure whether you noticed the country reduce the number of tests, so now it's few laboratories that do these tests. That's why we didn't do fixed recommendations. However, obviously, ideally, the Ministry of Health that controls the public network of laboratories should continue with the program. Unfortunately, the country does not have an entity that can make samples for evaluation. So the ministry needs to contact external organizations to do this, and this is not cheap. And we have other AFENET programs, and we have recommended this many times. And to remind of what the colleague said, the recommendations that when they are not feasible, we sometimes end up not including them. Since there was a limitation of time, the program ended and we don't have funding for continuation. The second question, the colleague wanted to know about the response time of the laboratory tests. These are tests, and the company responsible for sharing this sample shares it 1 month before the date of submission of results. AFENET and Angola do the monitoring of the laboratory response time, and this is not what we bring here because it's not an interesting or relevant indicator to bring, because everyone has submitted the response in time because we gave a lot of time. This is an indicator in another study. We simply wanted to include the number of the laboratories that participated in this program and the quality that they had, whether they got better or not during the cycle. I believe the same colleague wanted to understand why in 2022 the laboratories did not submit the results. That's because many of them were not doing the test for SARS-CoV-2. And these laboratories did not have samples because they did not have the reagents to do this external evaluation. That's why they didn't submit the results.
Thank you once again. My first question was, what was the percentage without latrine, and what would be the recommendation? Because of the existing problem in Central Region, the program Community-Led Total Sanitation, which is a participatory approach of mobilizing community members to build their latrines, was introduced to improve or reduce open defecation in the region. Also, for a community to be declared open defecation free, it is dependent on the number of household latrines that have been constructed in a particular community. And for that matter, some of the communities which triggering took place and they could not build latrines, we recommended that triggering activities should be carried out again. Maybe initially triggering did not go well, and therefore we recommended that that activity should be carried out again so that it will sensitize them well to build the latrines. For the second question, the cost of latrines in Ghana. When we compare the cost of building latrine in peri-urban or urban areas to that of the rural setting is much lower, because in rural areas you don't need much cost because you need the local materials to build the latrines. But just that the durability is the problem, because when one rainfall cycle happens, all the latrines can collapse. And because of the financial challenges of our people, sometimes when it happens and you are stressing on them to build another one, it becomes a problem. But we are still working with them so that even though when it collapses, because you have the local materials available with you, you can build another one. Thank you.
So, good afternoon again. The first question was, what influenced me to start the study on leptospirosis? So, I work as a medical laboratory technologist, and whenever I get a positive leptospirosis sample or positive case, we notify the ward and then the CDCU. So, while notifying the ward, when the nursing officer would tell me that the patient has passed away, that would create a blank moment. And we are supposed to, like with whatever work we are doing in the medical field, is to give a result so that the patient gets the treatment and he gets treated better. Now, when you hear that the patient passed away, it means that there was late diagnosis or misdiagnosis. So that's what motivated me. And as we can see, for example, I'll tell you, 2 days ago, there was floods in Mauritius. So due to climatic change, or maybe like construction, buildings, so we are having more floods and more rainfall. So this will become a zoonotic disease. It will become a pandemic sooner or later. So why not creating awareness and doing studies now so that we can, whatever will happen in the future, we will have already the actions there. Now the second question is, do we have a rodent control in Mauritius? So yes, we have. So we already have a passive-based laboratory surveillance which is in place. Now, what happens whenever we have a positive case, we will notify, because it is a notifiable disease, we'll notify the ward and the CDCU, that is the Center for Disease Control Unit and Prevention. So when we notify, they will notify the RPHS and start taking actions. So what actions they take, there's rodent control, and they will monitor the patient. My third question was, leptospirosis is under-notified. Why? Now, because we misinterpret the symptoms with hepatitis, for example, we tend to, as physicians, we tend to rule out, like we will use the rule-out method. We will test for LFTs, hepatitis, HIV, etc. And at the end, we will test for leptospirosis. We don't get that much request. So therefore, our work as medical lab technologists will increase. It's not a matter because it's our job. If we are having more requests at the beginning itself, instead of having the ruling out, like we will test for this, and lastly for leptospirosis, at the beginning itself, if we test for leptospirosis, it can be detected. So that's why it is under-notified till now. So if we create awareness among the healthcare facilitators or physicians, this will help out. And how can we reinforce surveillance? Now, normally, surveillance is for timely detection and completeness. So we are integrating the leptospirosis in our IDSR for the moment by the support of WHO. So this will reinforce the surveillance. We already have the passive-based surveillance. Now it will become at a national level. And why do we need to implement a One Health approach? Because it is a zoonotic and waterborne disease. So we are not testing for the leptospires in the rodent population or in the animals or in the cattle, or we are not even testing the contaminated waters, the area which has been contaminated after floods. So what happens is we miss out. And I have seen a study where the athletes, the one who play footballs, they were playing on the playground with contaminated waters, barefoot. So people don't know. I myself played barefoot on the fields. So what happens is if we don't test for that area, they will get contaminated. There are children playing, there are athletes playing like barefoot. We played for fun, but we can get contaminated because it enters the abrasion and cuts through skin. Right, and fourth question, sir, you are absolutely right. I totally agree that we need to quantify our recommendation. For example, I had a question, why we need to create awareness for leptospirosis instead of COVID-19, which requires more, like there was more death and it was more virulent. Leptospirosis is not that, that was my question, like why we need to invest money in awareness for lepto. We should have invested the money for awareness for COVID-19. Yes, I totally agree, but since leptospirosis is seasonal, we can have small awareness seasonally, or we can have awareness just prior to floods, just prior to heavy rainfall. And normally, even I will take example of myself, my parents do not know what is leptospirosis. So what happens is, if they take a can of soda, they don't wipe the above, rats, the leptospires, it's present in the urine of rats because it grows there in the renal tubules. So if a rat urinated, I don't know, in a surface or normally on cans, because in shops, we don't have control, like what is happening in shops at night, rats will roam around. Even if rats eat the bag of rice and we consume it, we will get the leptospires. So if we create awareness, like we tell people, okay, there's a disease known as leptospire, and it is mostly rodent or contaminated areas, so people will be aware of it and will be able to control the mode of transmission and will be able to avoid, like the actions, simple actions in the community. So, and also mass detection will be very costly. So it cannot be achieved quickly, but with time, of course, and small stakeholders' involvement, etc., we can achieve it in the future years. So that's why we are here. Thank you.
So a big applause to our presenters. I think they've done an excellent job in presenting and responding to those comments. I congratulate you for taking them on, those questions. You've done really well, so please put into consideration all the comments and questions in improving your write-ups. I'm hoping you're going to publish, and please consider the Journal of Interventional Epidemiology as your journal of choice when you're submitting. Thank you very much. I think it's time we break, and then we get ready for International Night.
Congratulations.